Hi, welcome. Thank you for joining us today. We wanted to use this session to tell you a little bit about our evaluation methodologies, how we've used that to improve clinical services and patient outcomes. I'm going to talk to you a little bit about the way that we go about evaluation, and Sarah's going to take you through a couple of examples, particularly one around prehab and cancer. So I think most people understand the benefits of evaluation and why it's important. It's how we can look at the effect of change and improvement, both the unintended and the intended consequences of that. What we've got on the slide behind me is the methodology for insights and approaching evaluation. So the way that we would approach evaluation is we are clinically driven. So from the very start, when we're understanding and scoping out the challenges, we have clinical input. We would then have a really MDT approach. So we bring in lots and lots of different specialities in SME that helps us from doing the solutionising right through to the implementation solutions. And I think, for me, I feel that evaluation is really, really important at the minute. So we are going through a period of change and transformation from system level change across to elective care recovery. And evaluation is the tool that lets us know whether we're doing the right things and we're doing things right. If you want to click for me, Sarah. So this slide just shows the plan, do, study, act cycle of evaluation. So we would start with a scoping exercise and defining exactly what we want to do. We have a lot of methodologies for evaluation. There isn't a one size fits all. We would employ a number of techniques. Some of them are formative, so that's where you will design evaluation into your service as you try a new initiative and you design it in from the start. Or summative, where we take a look back at the outcomes towards the end. Most of the evaluation requests that we get will not be neat. They won't be for one small intervention in a clinical area, but they'll be quite broad in scope. And so we use a pluralistic approach, which just means that we're looking at it from lots and lots of perspectives. So that could be the commissioning perspective, the provider perspective, the patient perspective, or the carer perspective. And that approach and methodology allows for that. So the way that we would start is to co-design, to engage, to get clinical input. And then the thing that I think that we do a bit differently that works really well is triangulating the evidence. So we'll start with an evidence search. We'll design a PICO, which is a clinical query, and we'll get the evidence out. And then what we do is we put an SME team together that takes that evidence for what's happening, marries that up with the data, and then if possible we would also add in and triangulate a qualitative approach. So that's where we would do surveys and work with our comms and engagement team to get lots of engagement with service users and get their perspectives and stakeholder perspectives added in. So I think for me it's about getting the right data at the start, designing something that fits what you're trying to do, getting the right data in, wrapping the SME around that we take listen to what the evidence is telling us, and then listen to what our stakeholders are telling us, and put that together to have a look at what's happening now and what changes we would recommend. Okay, do you want to push us on? So this is just a bit more specific around what SCW do. So I've said that it's a clinically driven operating model, so we'll involve clinicians both from ourselves within SCW. We have a number of clinicians that we'll draw in depending on what we're looking at, what the topic to be covered is. We'll also work really closely with the commissioners, clinicians, to make sure that we get it right at all stages. Evaluation can be done in-house or it can be done independently. What we offer is an independent voice while still being a trusted NHS partner. I don't want to say too much more about the methodology, because I'm going to hand you to Sarah and she's going to talk to you about cancer and prehab and exactly how we've used evaluation in these methodologies in that space to bring about change. For me, my personal feeling as a pharmacist with a background in evidence-based medicine and clinical effectiveness, I'm really passionate about it. I think it's the way that we should be building in evaluation to every new initiative, not something that we think about afterwards and we look back and see what happened there, what worked, what didn't, but actually we build it in from the start and we use it as part of our ways of working going forward.
Ready? Hi, so I'm Sarah Warren, and if you don't know me, I'm one of the Associate Directors in SCW. One of the services I work with is our Cancer and Long-Term Conditions Consultancy team. So one of the parts of that role is that we do service evaluations working collaboratively with different parts of the NHS. And we are part of a community practice for Prehab to Rehab, which is a model we've been passionately promoting with Macmillan and UK Active and a number of other national organisations, which basically takes the concept of rehab and places it at the very beginning of someone's journey at the point of diagnosis for cancer. One of the key people within the community practice that we've been working with is the Greater Manchester Prehab4Cancer team, and they approached us about 9 or 10 months ago to let us know that they were looking at sustainable funding and wanted an independent evaluation of their service. So we worked with them to look at what they were already collecting in relation to patient outcomes, quality of life measures, as well as service outcomes. And the next few pages are just a bit of a summary of what we found with them. It also builds a great case for change for other areas picking up prehab, but it's something that could be a model that goes much wider than just cancer. So it would work with pretty much most diagnosis, and so I know there's quite a few services across the country now that are looking at it as part of their pre-op assessment processes and any surgical pathway. So the main model for Prehab in Greater Manchester focuses on nutrition, exercise and well-being. Some of the more in-depth versions also look at meds optimisation as the fourth element. And the reason it works well to have that triangle or square around the individual is that you need to be taking account of the physiological changes that are occurring in the individual alongside their mental well-being to make them as ready as possible to undertake the additional physical exercise that you're asking someone to do. There was a lot of early studies that were showing that you would prescribe the exercise but they wouldn't have any nutrition advice and so had no energy, and people were keeling over halfway through their exercise program and no one understood why. Thank you. So, as I was saying, we were looking at a range of data to best look at the different ways that you would be deciding whether to commission a service long term. So we looked at the local data sets that Prehab4Cancer had, and they'd done a lot of longitudinal study work where they were taking information up to 12 months after discharge from their service, which is really helpful because often you don't get that 12 months post-discharge information, so it was somewhere we can actually demonstrate some really longitudinal value to the service. We also linked that using our brilliant BI team with SUS data and did some data analysis. This was a really collaborative piece of work between their BI team and ours, and there was some genuine cross-learning. So we've changed some of our ways of analysing data and what we would recommend elsewhere, and their BI team benefited from a significant skill upgrade, upskilling. The other bit that we were also looking at is the financial impact, so both from an efficacy and a productivity perspective, and we're able to use the SUS data but also some of that wider quality of life information to demonstrate how that didn't only do cash releasing savings but also thought about how you gained a greater benefit from across the whole of the patient pathway. You want to click on? So some of the key things that came out for this study that are particularly pertinent, and we were hoping we'd have Zoe here, who took this to the Conservative National Conference and has been tweeting a lot about it because it's made some really big differences for them. So people that participated in the Prehab4Cancer service had a reduced length of stay for up to 2 days in comparison to those that weren't part of it, and also a reduced length of stay in critical care as well. So in the current experience we've got of waiting list management and the impact that the pandemic's had in elective care, this is a really fundamental thing. So in colorectal alone, we got to a point where for every 1,000 patients that went through the pathway, 179 more patients were able to be seen because of the capacity that was released. The individuals that participated also had much better survival rates and went on to have ongoing health and well-being benefits, to a point where some are reporting that they are actually healthier for the diagnosis of cancer than they were before they started. And the fundamental difference between a prehab model and a rehab model is that they get longer whilst they're going through that diagnosis process to understand and embed behaviour change, so that when they're feeling really, really rubbish in the middle of their treatment cycles, they've already got some of those behaviour changes occurred, as opposed to having the trauma of the acute treatment and then having to try and make lifestyle changes at the other end, when, to be quite frank, you're probably going through a grief cycle about the life you had before your diagnosis. The last bit that people were really that helped as well was that these people were more activated. So not only are the patients gaining greater benefits from PIFU, patient-initiated follow-up services, but they also are more symptom aware and health aware, and they tend to spread that message to their local network of friends and family. So while we weren't able to get concrete evidence of that, there is a lot of anecdotal that demonstrates that we actually had the cancer prehab team seeing a wider population benefit for the work that they're doing with this particular cohort. Do you want to go move on? So the prehab to rehab model is something, I'll go on to this one in a second. The prehab to rehab model is something that we're extremely passionate about and really keen to look at how we make the most of both the face-to-face interventions that are already occurring in quite a few acute trusts at the moment, but also looking at how it can be more widely adopted much earlier in the pathway, and looking at community and GP practices and how you align that with the social prescribing work that's going on in a lot of areas. We also have a great clinical and non-clinical contact centre capability in SCW, so we're at the moment looking for a partner to come and do some collaborative work with us to explore how we could support a local prehab to rehab model with some universal offer work and some signposting and health belief coaching. So if anyone's interested, come and speak to us afterwards. Linked with prehab to rehab, one of the other things that was really pertinent is having care closer to home. Now, it's something that's been revisited several times in the NHS, but one of the things that became really interesting is that a lot of cancer pathways, as you become more and more specialist, turn into tertiary centres, which means that you can have very, very large geographical spread of the patients that are travelling. And that specialism means that people's pathways end up with very sick individuals having to travel 4 or 5 hours to access their clinical teams. So this pilot that we supported independent evaluation for Thames Valley Cancer Alliance looked at how you could change the pathway to making sure that the individuals for head and neck cancers were able to benefit from that specialist tertiary service when they needed it, but access their local services for other elements of their care. And one of the really fundamental things that was focused on in this was the patient experience and then the clinical outcomes. So while financial productivity measures were important, they weren't the driving force for this evaluation. And because of that, it's been quite powerful because it's helped to engage different decision makers in thinking in a slightly different way. Do you want to move on? So the key outcomes that came from this was, strangely enough, feeling really ill, very frail, and having to travel 4 hours to get a tracheotomy checked or to have a routine procedure undertaken is something that not many people particularly enjoy. So the patient outcomes data showed that they were happier to be able to travel less far, but more importantly, and probably more pertinent from a clinical perspective, they were reporting, and it was backed up in the clinical outcomes, that they weren't waiting as long on the symptoms they were experiencing. So people weren't waiting to get to a point where an infection had turned into sepsis before they sought help. They were seeking help at the point where there was something not quite right, but they weren't sure what it was. And the main reason for that was because it wasn't a 4-hour barrier of travel to go and just check it out. It was just down the road. The other thing that made a big difference is the specialist tertiary centres came to the local areas. So you still had that specialist input, but it was happening in Swindon rather than in the middle of Oxford for those patients. The final element to this, which was really meaningful from a financial perspective, is that there was a reduction in how many A&E attendances and admissions thereafter occurred, and that's partly because people were attending at an earlier stage and being able to be resolved much quicker. But this particular cohort are highly frail. They're also more likely to be in some of the lowest socio-economically deprived groups of the population. So travel for them is a particular challenge because they don't necessarily have access to their own cars with the financial means to travel and pay for the fuel to move, but may not be quite sick enough to benefit from patient transport. So this was also seen as a contributing factor to those clinical outcomes. So that's a whistle-stop tour. If there's any questions, welcome to take a few now. Otherwise, we'll be at the stand for the rest of today and tomorrow.